Good afternoon, everyone. Can everyone hear me well?
Okay, I think somebody said yes.
Yes. Okay, good afternoon, everyone. Our lecture for today is chronic back pain, an over-medicalized and over-treated condition. This will be presented by Dr. Noor Abdal. She's a musculoskeletal physiotherapist who specializes in the management of chronic pain. She has gained her master's and PhD from the University of Brighton in the UK, and is currently the clinical manager at the Borough Rehabilitation Center, which will be opening soon. Friends and colleagues, let us all welcome Dr. Noor Abdal. Welcome, Dr.
Thank you very much, Carlos. Good afternoon, everybody. It's a pleasure to be with you today. As Carlos said, I'm a musculoskeletal physiotherapist, and one of the things that I looked at in my PhD is I was very interested in understanding people's subjective experiences with chronic low back pain. Because as you all know, as clinicians, when we deal with back pain in the clinic, you tend to find that the clinical presentation varies significantly among different individuals. So even when individuals walk in with the same diagnosis, whether it's a disc prolapse, whether they've got degenerative changes in their spine, even with spondylolisthesis and things like that, clinical presentations vary. So the site of pain varies, the exacerbating factors, movements that reduce the pain, movements that increase the pain, times of day where people feel the pain, and their pain trajectory in general is very variable. And this really gave me an appreciation that listening to our patients, understanding their subjective experience of pain, because at the end of the day, pain is a subjective experience. We don't have an objective measure where we can clearly measure our pain. And so it becomes very important that we listen to our patients and understand how they perceive their pain. This is what I want to talk about today. My talk is going to be based on the evidence, but it's going to be very clinically oriented, because I think one of the things we struggle with as clinicians is how to interpret evidence and how to take that evidence and apply it clinically. So I'm going to tell you a little bit about my take on the evidence, my take on the literature, my reading all of those years, my investigations, my personal research, some of the conclusions I came up with in terms of how to understand chronic pain, how to explain chronic pain to our patients, and some of the tools we can use to help them manage their pain more effectively. So I'm just going to give you some statistics, because I think it's important that before we start thinking about managing back pain or providing the most effective treatment programs, it is important to reflect on our personal understandings of pain, shift our mindsets in line with the evidence in order for us to provide better guidance for our patients. So if we're thinking about chronic back pain, some statistics from the literature. So it suggests that between 50 and 80% of the worldwide population, adult population, will suffer from back pain at one point in their life. And let's bear in mind that these are only the statistics that have been reported. So this is only reported back pain. So from your personal experience with back pain, I'm pretty sure that you have experienced back pain. Everybody that's listening to me has experienced back pain at one point in their life, or they know somebody who has experienced back pain as well. And sometimes that, a back pain that lasts a day or two, or sometimes even a week, we don't even report it. So the statistics might even be higher than that. So if 80 to 90% of the world population will suffer from a back pain episode at one point in our lives, it's very unlikely that this is a pathological condition. It wouldn't make sense that 80% of the world has a sickness, they have a disease. So this starts giving us an indication that we need to start normalizing back pain. We will experience back pain, it's inevitable. But what do we do with this back pain and how we manage this back pain? This is what I want to talk about. There's also a lot of evidence out there that suggests that it is a multifactorial condition. And there are specific psychosocial aspects of the pain experience that we can't neglect. There are lifestyle factors that we can't neglect. There are a lot of beliefs and behaviors around back pain that we need to consider. And so we need to stop thinking about it as a pathology. Another interesting statistic that I really like, and it really kind of ties into what I was talking about a minute ago. Can we really explain back pain medically? So what we know now from the evidence is only 5% of back pain can be correlated to a pathology. So only 5% of back pain we can explain using an MRI, using an X-ray, correlated to an intervertebral disc prolapse or a traumatic back pain such as a fracture or a malignancy or an infection or a neural disorder. So that all of those things that I talked about only explain 5% of the back pain that we see in our clinics. 95% of back pain we cannot explain with those things. So all of those medical investigations that we have cannot explain 95% of the pain that we actually see in our physiotherapy practice. And so it is very unrealistic to ignore this evidence. This evidence has been available for years now. So many studies have iterated the same statistics. It's very unrealistic that we have this evidence and we try to squeeze all of our patients into an intervertebral disc prolapse or a degenerative change or a spondylolisthesis. It doesn't make sense. So we need to start thinking outside of the box. We need to think, what is causing 95% of people's pain? More statistics. I'm also sure that you're aware of this study, but there are studies similar to this as early as the 90s. So these studies have been out there for 30 years and more. And what they're saying is, when they actually carry out MRI studies with asymptomatic people, so people that are not suffering from back pain, they find that as age increases, those changes in the spine are evident. So if you can see from the slide, by the age of 50, 80% of asymptomatic individuals will have some disc degeneration. And so those statistics give you an indication that actually this is a normal process that occurs with age. It is not necessarily pathological. There are going to be changes in our spine. It is not normal. We're loading our spine. We're using our spine for movement on a day-to-day basis. The spine is a very complex structure. We've got multiple joints. We've got multiple ligaments. We've got multiple muscles associated to that spine. So it starts all the way up from the shoulder joints, going down to the ribs, going down to the hip joint, going back to so many structures. So it's very unlikely that that spine is going to look, brand new and polished throughout those years. There are going to be changes, which is normal. Disc protrusion, what they found again is by the age of 50, more than half of individuals present a disc prolapse in their spine, and they don't suffer from any pain. So basically what they've concluded is there's a very poor correlation between those common diagnoses that we see in the clinic and back pain. And again, so when you're presented with those diagnoses, you need to be very careful how to interpret them and how to correlate them to the patient's symptoms and the patient's pain presentation and what they're telling you about their pain. I'm going to talk a little bit more about that as we move on. So, as I said, when I did my study, I was very fortunate to follow up the woman in my study for a year. And it was very interesting for me because it gave me an opportunity to see how changes in their social circumstances, changes in their social relationships, changes in their socioeconomic status, their cultural beliefs, their social beliefs, even their emotional representations of their pain, how they varied throughout time. So sometimes when we see people with pain, we see them during their pain episode. We see them during an exacerbation of pain or following a trauma in the acute stage. But we're not very fortunate to see those patients a year after or 2 years after. Sometimes we do, but they come back because they've got pain. They come back because they have another pain episode. So we're not very fortunate to see when they're not in pain, what's actually happening in their lives. So what I found is a lot of those things, a lot of those factors, changes in those factors are associated to periods where they have remission of pain or periods where they have exacerbation of pain. So what the biopsychosocial approach suggests is that we don't neglect pathoanatomical problems. You don't neglect the physical or the neurophysiological, but we also need to consider that there are psychological factors, there are cognitive factors, there are also social and lifestyle factors that can be associated to the back pain presentation. So this is kind of systematic way of how I usually deal with back pain. So I'm going to talk about some of the questions that I usually ask. So the first thing we need to do as healthcare providers is we need to rule out a pathology. So we need to make sure that this pain is not associated, whether or not, so we need to make sure that we know that it's not associated to a pathology before we move on to considering all of those things that I was talking about. So some of the things that we need to ask or consider are things like malignancy. So you do need to ask about things like sudden weight loss, if there's family history of cancer. You need to consider the patient's age as well. When we're thinking about cold equina symptoms, you need to think about things like saddle anesthesia. You need to think about things like motor sensory impairments. Modic changes are actually when there's a rupture in the disc, and you've got all of those chemicals inside the disc oozing out on the nerve. So there's a lot of studies out there that say that modic changes, especially in their more advanced stages, can be associated to radicular symptoms that we feel in the leg. So we need to consider, again, we do need to consider the MRI. We do need to see the changes in the MRI, and we need to correlate it to that patient's presentation. So if the patient is saying that I can feel the pain in both of my legs, and it's very painful, or if I can feel it in one leg going down, and you see that you've got a rupture in that disc, for example, to the right, then that may give you an indication that actually, yes, we have an inflammatory process going on, therefore that nerve is sensitized, therefore it's causing those symptoms going down the legs. Intervertebral disc prolapse, again, very important. So if I have an L4, L5 disc bulge, let's say centrolateral to the left, and the patient is coming in, and they're saying that I have pain, and it's in my back, and sometimes it goes up to my mid-back, and I feel pain in both of my legs, and I feel numbness in both of my feet and all of my toes. That's very common. That's a very common clinical presentation that I see on a day-to-day basis. So if I have an L4, L5 disc bulge, centrolateral to the left, anatomically speaking, if I want to follow that nerve distribution, I would probably feel some radiating symptoms in my left thigh. Maybe I feel some radiating symptoms towards the tibial muscles. It's very unlikely that I'm going to feel symptoms in my toes, and it's very unlikely that I'm going to feel symptoms in both of my legs and in the mid-thoracic spine. So again, if you see that disc prolapse and you're listening to the patient, and there is no correlation between what they're saying, their pain presentation, and that prolapse that you're seeing in the MRI, you need to come to a sound clinical decision. Is this actually radiating symptoms, or is it actually more complex pain that I need to consider? Fractures, so we need to ask about traumas, if they've had a direct flow to the back, if, for example, they're an athlete, for example, this is very common among horseback riders, has she fallen off the horse? Is there a direct trauma that may alert me to the fact that there might be a fracture, and I might need to send them to further investigations? Inflammatory pain disorders, so questions I need to ask. With inflammatory pain disorders, the pain is usually constant. It's usually aggravated by all movements, so there aren't any particular movements that reduce the pain. They're always in pain. Night pain, so I need to ask, does the pain increase at night? Usually night pain is associated to inflammatory disorders, whereas morning pains are more associated to mechanical disorders. So I need to be aware of all of those things, and I'm really stressing how important it is subjective, to get this subjective information out to the patient, to ask those questions in order to get some significant information from the patient so that I can build my clinical picture. Looking at an MRI or an X-ray is not enough. Neuropathic pain disorders, again, do I have a problem? Do I have diabetes? Do I have another immune disorder? Do I have a trauma where I'm suspecting that I might have injured the nerve? Do I have any motor deficits? Do I have problems in reflexes? Do I have sensory deficits? All of those things we need to consider so that we make sure that we have considered any pathology that may be causing the pain. So we have considered that 5% that I was talking about. If we don't find any of those things, then we need to start thinking outside of the box. Now, I've talked about those things because I want to make sure we stress that when we're talking about psychosocial aspects, we're not denying pathology. We're not denying that it's important, that it can be very dangerous, that we need to be very aware of it in case we need to intervene, or we need to refer a patient for a medical or surgical consult before we intervene. But in my personal experience, and I'm sure all of you will share that experience, is most of the time the patients that walk into into our clinics don't have those clinical presentations. They come in and they have pain, and the pain is very diffuse, so they can't localize the pain to a specific region. And it's been there for years, 5 years, 10 years, sometimes even 15 years. It's gotten worse over the years. It starts interfering with their activities of daily living, so they can't walk for a prolonged period of time. They can't lift objects. They can't carry their children if they have youngsters. They can't drive for a prolonged period of time to finish their errands, to pick up their children from school. So it's a very disabling condition. And when we suffer from disability, we need to be very aware that disability can have a significant impact on how we feel. Because it doesn't feel good that I can't walk for 10 minutes. It doesn't feel good that I can't drive to my kid's school to pick my kid from school. So it's very important to listen to those things, because how a patient feels impacts their back pain significantly. And now we know that there's a lot of evidence that suggests that workplace stress, social stress is directly associated to pain, because all of those things lead to changes in the immune system, they lead to changes in the nervous system, and as an effect of those things, the musculoskeletal system gets impacted. So the reality of back pain, it is very complex. There are a lot of beliefs associated to back pain. And us as healthcare professionals as well are guilty. So for example, if a patient walks in and they say, I have back pain and it goes down to my left leg, and I look at the MRI and I don't ask any questions, and directly I say, yes, you have a disc bulge, and therefore the disc is impacting the nerve, and therefore the nerve is causing pain in your leg. That is a very restricted view. I ignored all of those other things that could be associated to back pain, and therefore that's gonna lead me to develop a very, very restricted treatment plan. And it's gonna lead to a lot of problems, because if it doesn't make sense to the patient, then the patient will not adhere to it. And sometimes we blame the patient. Why are you not sticking to your exercises? Why are you not doing what I tell you? We follow a very prescriptive approach, when actually the problem is us. We haven't understood the problem properly. Therefore, we haven't analyzed that problem properly. Our clinical decisions become very restricted. Therefore, the treatment plan becomes very restricted. Therefore, it doesn't make sense to the patient. And if it doesn't make sense to the patient, then the patient is not going to adhere to it. So again, as I say, sometimes we need to take a step back and think about what we are doing before we blame those patients for not getting better with their pain. And this is a very nice study about what I'm talking about. So there's evidence out there to support this, that the more biomedically oriented I am as a therapist, the more I'm going to affect the patient's attitudes and behaviors towards their pain. So for example, if I'm very biomedically oriented, and as soon as I get an intervertebral diagnosis, I decide that this disc has shifted from its place, and that I need to be very careful, and I need to advise the patient to stop lifting, to stop pushing, to stop pulling, to take rest. What am I doing? I'm reducing their activity. I'm letting them take days off work. I'm making them feel very restricted. I'm increasing their stress levels. I'm making them more depressed. I'm making them use their muscles less actually with time. So in the long run, I'm actually making their pain more complex than helping them. And if I have personal fears, if a physiotherapist has some fears around, for example, this is very common with back pain, and we hear it with professionals all the time. So I say to the patient, for example, the patient is going to the gym, and then they have a back pain, and then they come to me, and then I say, you have a disc prolapse, you're not allowed to squat. The squat is actually a very functional movement. And from a lot of the patients that I see in my clinic, we know now that a lot of the pain that we see in Kuwait is associated to sedentary lifestyle. When people are very sedentary, we find that their core muscles become very deconditioned, their glutes become very deconditioned, they start compensating with their back. And so if I'm avoiding that squat movement, I'm actually avoiding them from inducing some control and some strength in their glutes and their control and their core, sorry. So in the long run, actually, I'm making their problem worse than making it better, just by giving them information based on my personal fears. So we need to be very aware of our beliefs around back pain and change them in line with the latest evidence, so that we can provide the most effective advice and treatment program to our patients. So our aim is not to prevent back pain. Our aim is to give the patient tools to manage it. Back pain is not the enemy. I'm going to feel back pain, you're going to feel back pain, everybody around us is going to feel back pain. It is going to happen. It is not a problem. That is not my problem. What I want to do, and it is very important I say this because, for example, if my patient walks in and she has an NRS of, let's say, 7, and I'm treating her, and 2 weeks, 3 weeks down the line, her NRS goes down to 5. So it doesn't significantly go down, right? It was 7 and it's 5. If I have this expectation that I need to limit, or I need to alleviate the pain, or I need to just, make the pain go away, I will give the indication to the patient that actually there's something wrong. The treatment is not working, or she's not adhering to their program, because I'm very restricted in my thinking. I'm thinking of that pain. But when we're thinking about chronic back pain, it's more complex. She might have an NRS of 5 out of 10, but during those 3 weeks, maybe she was able to walk for 10 minutes when she came in. Now she's able to walk for 20 minutes. Maybe she wasn't able to, for example, let's say, carry her bag while she's walking. Now she's able to. Maybe she wasn't able to carry some grocery bags out of the grocery store, and now she's able to carry 2 grocery stores as she walks out. And so if we think, as I said, if we think of a more multifactorial condition, if we're thinking about disability, if we're thinking about function, if we're thinking that she's able to manage her pain more effectively, then the way, when I look at those things and I say to this patient, we've done this, we've done this, we've done this, she's going to feel much better about her back pain than when I focus on what I need to do is reduce that NRS. And if we haven't reduced that NRS, then we have failed. Okay. Very important slide. I'm going to spend some time on this because, again, when we're looking at pain presentation in the clinic, I've talked about the subjective history. I've talked about some of the questions that you need to ask the patients. But what about the pain presentation? And what about how we vary between an acute pain and a chronic pain? So with acute pain, usually the pain follows an injury or it follows a trauma. So for example, if I have a patient and they go to the gym and they did a deadlift. So let's say that they weigh 75 kilograms. So this person weighs 75 kilograms. And then they suddenly lifted 100 kilograms. They haven't moved and they haven't warmed up properly, and they developed a QL strain. Okay, so usually there's an incident that happened. There's a mechanism of injury that happened that led to their pain. With chronic pain, usually it's not very clear. So usually the back pain person would walk in and you would ask them, how long has the pain been there? And they would say the pain has been there for 5 years and it's been getting worse. And you ask them, can you associate it to something in particular? And maybe they would say something like, I'm not sure. Or maybe they would say, 10 years ago, I lifted heavy objects. Now you need to be very aware. Again, you need to be very clear. With a strain, whether you have a muscular strain, whether you have a tissue injury, usually the healing time is 3 months. If it's more severe, it might take 6 months. If it's, for example, a road traffic accident, whatever, it might be a year. But the point is tissues heal. So if they carried that box or those boxes 10 years ago, and they have been suffering from back pain for 5 years, and they're not sure what caused the back pain, then it's very unlikely that those boxes are associated to that pain. But again, it is very important for us to ask those questions in order to see what the patient beliefs are around their pain in order to correct them. Because all of the latest evidence suggests is when you educate your patient, when the patient understands what the pain is being caused by, when you de-threaten the patient, it is very likely that you are providing a better prognosis for this patient. With acute pain, again, it's usually localized to the site of injury. So if I have a QL strain on the left, then usually that QL is very tender, and usually it goes into a protective brace. So the patient might be leaning to one side, they might be extended, they might be trying to protect that muscle. They will have very protective behaviors. Usually when you palpate that muscle, it might be a bit tense. But when you palpate, for example, the left shoulder or the right shoulder, it is very unlikely that you're going to have any pain. With chronic pain, it is very different. Palpation can tell you a lot because they are usually sensitized, because usually their nervous system is sensitized. Sometimes they have pain around the back, but just palpation, even sometimes with very light touch, you will feel that they get very tense. And sometimes when you're working around that pain, so if you go lower down the glutes, if you go higher up in the thoracic spine, sometimes just with palpation, you would induce a painful response. Not because you have a pathology, but because the nervous system is sensitized. So this is very common and something to look out for when you're assessing your patient. With acute pain, it is usually mechanically provoked, which means is, so that QL, when it's strained, okay, if I activate that QL further, I will probably exacerbate that patient's pain, right? Left, and I'm doing hip flexion on the right. It is very unlikely that I'm going to provoke that pain. So there are specific movements usually that provoke the pain with an acute pain. With chronic pain, we have something called mechanical hyperalgesia. This is very common with my back pain patients. So for example, the patient walks in, I ask her to flex, she feels pain. I ask her to extend, she feels pain. I ask her to do some side bending, some rotation. I ask her to squat. Whatever movement I ask her to do, she feels that her pain is being exacerbated. It is sensitization in her nervous system. She's got a lot of fears around those movements. So her brain is being very protective because pain is a protective mechanism. We're feeling pain, it's a good thing, because if that patient didn't feel that pain in his QL, he wouldn't seek attention. He wouldn't know that this weight is actually too heavy. He wouldn't know that he needs to make adjustments. And he would just continue lifting that weight. And in the long run, it would lead to more complications. So it's an adaptive response in the acute stage, but it becomes maladaptive in the chronic stage. So we talked about this. If it's short lasting, less than 3 months, it's usually within the acute stage. If the pain has lasted after 3 months, beyond tissue healing, then we start thinking it's actually more complex. It could be associated to other factors rather than pathology. As I said, pain is protective. It is there to minimize harm. It is there to tell us that we need to change our behavior, that we need to seek attention, that there's something wrong we are doing. Whereas when we give, so for example, with this patient, there are two scenarios. So if I have a QL sprain and I can't walk, and sometimes they come into the clinic actually on a wheelchair, there are two scenarios where this can go. They walk into a medical health care, they ask for an x-ray, and then they tell them that they've got a mild scoliosis, lumbar scoliosis, and then they ask for an MRI and they tell them that they've got a disc prolapse, and then they tell this patient, okay, so you've got a mild lumbar scoliosis and you've got a disc prolapse, therefore you can't do deadlifts, you can't squat, you can't lift weights, you can only walk, you can only swim, you can only walk around the swimming pool. Can you imagine how outdated this information is and how restricted our thinking is? We've based it solely on that image. This could have been there for years. This scoliosis could have been there for years. It may be a functional scoliosis, it may be a structural scoliosis, but because of that very restricted thinking, I have given that patient very detrimental information. So in the long run, they stop lifting, they stop going to the gym, they become more sedentary, they have more fears around their pain, they develop more protective behaviors because they're very scared, that they think that their back is very fragile. And as a result, in the long run, I've led to a poor prognosis. I've led to a more complex pain rather than helping them. But if they walk into my clinic and I say, okay, you've lifted this bar, it was too heavy, you were in your office for 7 hours, so your body wasn't ready for that load. You walked into the gym, again, your body was not ready because you didn't warm up. And if I talk to them about their training history, I realized that they moved on to that weight too soon. So I would give them a recommendation that this is too soon, your body isn't ready for it, and this is where my role is. I walk in and I help them build to that if it's necessary. But on the other hand, I can ask them, what are your goals out of going to the gym? Are you an athlete? Are you a competitor? Or are you just doing this for fitness purposes, for health purposes? So if they tell me that I'm doing this for fitness and health purposes, again, I would give a recommendation that for fitness and health purposes, in terms of your lifestyle, in terms of how much you weigh, you only need to carry this amount of weight. And therefore, throughout my rehab, I would help you gradually with this strain. We will gradually increase the load. I will help you with using the proper muscles, and we will build up to an acceptable weight, which matches your goals. When I've given a very in-depth when I've done a very in-depth evaluation of this patient's pain, when I've asked all of the questions, I actually say, don't worry about this. This pain that you're feeling is healthy. It's very good. It's telling you that you sprained this muscle. It's telling you that we need to take care of this muscle, but don't worry, we will take care of this muscle. And then through gradual load, I reassure him that the movement is okay. Maybe I will do a deadlift, but I'll do a deadlift with a very low weight to start off with, just so that he doesn't develop fear around this movement. I'll educate him while we're moving, and I'll increase the load gradually. So can you see how those two scenarios are very different? And then he goes back to the gym, he does his deadlifts, he lives his active lifestyle, and he deals with his pain in a much better way. Finally, with acute pain, stimuli and response are usually coupled. As I said, when you move towards that muscle, when you're activating that muscle, or when you're straining those tissues, you'll feel a pain. But usually if you're moving the shoulder, you wouldn't necessarily feel the pain. With back pain, it's very common that the stimuli and response are not coupled. And something very common that you see with chronic pain is signs of allodynia. As I said, allodynia is a painful response to a non-painful stimuli. So if I put a very low pressure on that back, very low touch pressure through palpation, you might feel that the patient is getting very irritable. They become very sensitive. Sometimes they say that the pain is going up to their mid-back. Sometimes they say that the pain is going down to their legs. They're very irritable. And hyperalgesia. So this is very common in the clinic. Sometimes patients walk in and they say, when there's cold temperature, my pain gets worse. When it's humid outside, my pain gets worse. Those stimuli are non-painful, they're non-threatening, but when you have a nervous system that's maladapting, that's very common, and you can use those tests in the clinic. So you can use the thermal test, you can use some cold tests, you can use pressure tests, all of those tests, and if you feel that there are abnormal responses with your patients, this is giving you an indication that actually we're moving away from pathology, and it seems like this is a more sensitized patient that we're dealing with. I talked a little bit about this. This is the fear avoidance model. Again, this has been used in research a lot throughout the years. It's something very interesting to look into, to read into. Basically, what it's saying is when you give the patient threatening illness information, because why does the nervous system become sensitized? If I have beliefs in my brain, if I'm scared, what is going to happen? I'm going to want to protect my back. How is the brain connected to your back? Through your nervous system. Because your nervous system is getting all of those stimuli, it's reacting and it's sending signals to your brain. That's how your brain communicates with your back. So if my brain is scared, if I'm scared, then my brain is scared, then automatically it's going to make those nerves around the area more sensitive. They're more easily excited because it wants to know about it all the time. So if I scare the patient, I'm leading to what we're calling pain catastrophizing. So for example, if I say to the patient, don't lift anymore, the patient will avoid lifting, not because they have evidence that this is painful, but they're anticipating the pain based on what I said. And so they start avoiding all of those things in their life because they're scared of the pain rather than because this movement induced some pain. So we have some pain-related fear. It will lead to avoidance behavior. So with a lot of my back patients, how I deal with them is I try to alter their avoidance behaviors. They become hypervigilant, as I said. Then we have all of those physical changes. We're not saying we don't have all of those physical changes. So sometimes a patient walks in and you might find some motor impairment or a motor control issue. You might find an imbalance issue where they're using some muscles more than others. You might find a deconditioning issue or a weakness issue where you feel that they're weak all over. But you need to be aware that those things maybe did not occur because of a pathology. They occurred because those patients have spent years avoiding movements, avoiding lifting, avoiding carry weights, avoiding walking for prolonged periods of time, avoiding going up, down the stairs, avoiding sitting on the sitting on the floor, avoiding praying on the floor, which is very common. So they've avoided all of those movements in their lives, and you can imagine how this affects their musculoskeletal system with time. It also leads to depression. Because if I can't do the simple tasks that I need to do in daily life, sometimes we take them for granted. But if I can't lift my child, or if I can't pray on the floor, or if I can't drive for 10, 15 minutes, that leads to some depressive feelings. And as we said, there's a direct correlation between depression and sensitization of the nervous system and chronic pain, and it leads to disability. So why I'm giving you this model, again, trying to reiterate what we say to patients and how we perceive pain can really detriment them both psychologically and physically, because psychological effects are directly correlated to the physical changes that we see. So, targeting cognitions is very important, as I said. I talked about it, so I don't want to waste time on this slide. Hands-on therapy. What's it really doing? I'm not against hands-on therapy, but there's a lot of evidence out there that suggests that in order to deal with chronic pain or chronic back pain in particular, we need to help the patient become more self-efficient. We need to help the patient feel that they are more in control of their pain. I'm not against those interventions as long as we know, again, why we're using them and how we're administering them. So let's see what the evidence says. This is a very interesting study. What they did is they had 117 participants with back pain, and they divided them into 4 groups. One group received interferential current for 30 minutes, and they had the therapist sit in with them during that time. And during that time, the therapist was developing a therapeutic alliance with the patient. So they were asking them questions, they were explaining to them what they are doing during therapy, just building that rapport, building that relationship with their patients. And then they had the other group where they didn't receive, they had the electrodes placed in the same place, but the current wasn't turned on. So they didn't get any IFC, but the therapist was there. Again, for the 30 minutes, the patient thought they were getting it, and the therapist was there doing the same thing. For group number 3, the current was turned on, but the therapist was not there. So basically they were lying down with the IFC for 30 minutes by themselves. For the 4th group, they didn't get IFC. They had the electrodes. They told them they were getting IFC, but they didn't get any IFC and the therapist wasn't there. What they found was the participants that received IFC, but the therapist was not there, so there was no therapeutic alliance being developed, they showed clinically insignificant results on their numerical rating scale and pain pressure threshold. So they measured those 2 variables, a change in their numerical rating scale and a change in their pain pressure threshold. And they found that the results when the IFC was on and the therapist was not there were clinically insignificant. On the other hand, the people that got sham IFC, so they didn't get any IFC, but the therapist was there developing a therapeutic alliance with them, they demonstrated better results than the people that got IFC, but the therapist was not there. So this is really showing you that, and this is just one study, but when we look at the studies out there, there's a lot of controversy about the use of electrophysical modalities, and at best, they're providing a placebo effect. So it is not wrong to use them, but as long as you're aware why you're using them. So sometimes the patient may walk in and they're very irritable and they're very scared, and whatever movement you try to do, they just wouldn't do it. It is very unrealistic for me to walk into the gym at that time. I need to do something. So maybe I can use that modality, but being aware that I'm not sure that that modality is providing a therapeutic effect, but I'm using it to develop a therapeutic alliance with the patient. I'm using it to calm the patient down so that I can move on to my rehab. Manual therapy. I'm a fan of manual therapy. I use manual therapy, but again, we need to be aware why we're using manual therapy and how we're using manual therapy and what the evidence is saying. So what the evidence is suggesting is that we don't have any evidence to suggest that manual therapy has a mechanical effect. So if I do a PA mobilization on C4, C5, there is no evidence out there that I am actually mobilizing the joint or the vertebra or the facet joint or whatever it is. We cannot prove that. The only way we can prove that is by putting a probe directly into the spine to see if we're inducing the movement, and obviously that's unethical. We can't do that, so we don't have any evidence to suggest that we have a mechanical change. And when we think anatomically, we've got 3 layers of skin, we've got the fascia, we've got the muscles, we've got the ligaments, we've got the tendons, and we've got the spine, all the way in the middle of our body. So it's very unlikely that by providing some pressure on the surface, I'm leading to a mechanical change. But what do we know? We know that manual therapy has a gross neurophysiological effect. So not a specific, but a gross one. So there are changes in blood flow. And we know that changes in blood flow are really well. We see that when we provide our manual techniques, you directly see erythema, you see redness of the skin, you know that you're inducing a change in blood flow. And that's therapeutic. That's therapeutic for the nervous system. It's therapeutic for the musculoskeletal system. So that's good, but it's not specific. We see changes in heart rate. So sometimes if the patient is scared, the heart rate will increase. So you need to be very aware that you're explaining to the patient why you're administering, how you're administering, communicate with the patient, looking at the patient's facial expressions while you're administering the technique. Changes in respiratory rate. So that if the patient is relaxed, you will see that they're taking deep breaths, that the respiratory rate is reduced. And actually, during manual therapy, this is one thing that I do, because I personally use manual therapy to induce some relaxation in my patient and to develop that rapport, that connection with my patient. So I would give them some diaphragmatic breathing. I would focus on the breath. I would focus on administering the movement as they breathe. It is very therapeutic. It really enhances relaxation and it helps those muscles really relax before I move on to my rehab. And there are changes in diastolic pressure. So no evidence of mechanical effects, but it doesn't harm to apply those tools to get a neurophysiological response. I'm also a fan of mobilizations with movement. So sometimes actually you can use manual therapy during your rehab. So let's say, for example, I've got anterior shoulder pain. And when I see how that patient is lifting or whatever, I see that she doesn't have proper scapular activation. Okay, I could actually use my hand and give some feedback. So I'm putting some pressure on that scapula to give her some feedback that she needs to activate her muscles. At the same time, I'm providing some support on her shoulder because she's scared to move. She's scared of the pain. So I'm giving her some reassurance that I'm there with you. Don't worry, we'll move together. I'll hold it if you struggle. So you can actually use those things for reassurance. You can use it for rapport. So use those tools, but think outside the box, move away from mechanical reasoning and think more grossly about why and how those tools can help you with the management of your patients. Finally, exercise. Again, the evidence out there suggests that exercise is the most beneficial treatment for chronic back pain in particular and chronic pain in general. In terms of exercise specificity, it doesn't really matter because studies have varied with intensity and type of exercise. So isometric exercises work, stabilization exercises work, strength training, proprioceptive exercises, relaxation and breathing exercises, even behavioral support is really beneficial. So when you're thinking about back patients, as I said, a lot of them are avoiding movements. So they develop some compensatory patterns. So what you want to do is through behavioral change, you want to change that compensation that they're using in order to reduce the pain. So for example, if I'm scared of activating my back muscles because I have back pain, right? And as a result, if with time I'm deconditioned because I'm not moving very much, and this is something I see very commonly. And I'm not walking very much, and I'm not climbing the stairs very much, and I'm not, as I said, I'm not sitting on the floor very much, and I'm not a very active person in general, or my patient is not a very active person in general. Then you would find that their glute muscles are weak, their core muscles are weak, their quadriceps are weak, their hamstrings are weak, so many muscles are weak, right? And she says that I have a problem standing out of the chair. That is her problem. And then you decide that you want to give her some bed exercises, some bridging, some straight leg raising, some clam exercises. I mean, you can argue that I'm working on the right muscles, right? We can argue that those exercises are working on the right muscles. But are we really giving her what she needs? She's not able to stand out of the chair. So why don't I use a chair squat instead? I've targeted all of those muscles. I'm working more functionally because I'm thinking more functionally now than specificity. I'm not specifying muscle weakness. I'm thinking more muscle deconditioning due to disuse. I'm giving her a more gross movement, and I'm giving her a movement that makes sense to her. Because if I give her the exercise out of the chair, there's a higher she's more likely going to adhere to this exercise because it makes sense to her. I'm helping her stand out of her chair, rather than she telling me that I can't stand out of the chair and I'm giving her some bed exercises. So be very aware, specificity doesn't matter. Think about the function, think about the disability, and try to tailor your exercise to what she can't do. So if she says, for example, that I can't lift something and put it in the cupboard, that's another problem she can't have. I can give her a chair squat with a shoulder press. It makes sense. So when I give her a dumbbell and she's doing a shoulder press, it makes sense to what she can't do functionally. At the same time, I'm working on scapular control, I'm working on core control, I'm working on her glutes, I'm working on her legs, I'm working on all of those muscles, and with time, I can give her some advice. So for example, she does the first movement and it's very painful. So I explained to her that your nervous system is sensitive, so the first movement might be painful, but as you repeat this movement, your brain is going to feel better, that it's safe, that actually this is not threatening because you were anticipating the pain. And slowly, slowly, we work through those movements, we increase our repetitions, we increase the weights that we're using. So this is what I'm trying to say. Focus on the function, not on the specificity of exercise, because it doesn't matter. Other benefits of exercise. So we now know also that exercise improves brain function. The hormonal imbalances that happen with people with chronic pain, there's evidence to suggest that when you follow a more healthy lifestyle, you can improve those imbalances. So you increase happy hormones, dopamine, serotonin, things like that, and you reduce pro-inflammatory hormones that are associated with neural sensitization. It decreases pain sensitivity. So there's a lot of research out there, which I recommend you read, about exercise-induced hypoalgesia. So we know now that hyperalgesia can be counteracted with exercise. And most importantly, it helps eliminate fear avoidance behaviors. So sometimes you need to use movement, use exercise to reduce patients' beliefs. To reduce patients' fears, to alter those negative beliefs around their pain and help them function more normally, reducing their disability, improving their quality of life, reducing those depressive thoughts and feelings that they have around their pain, to provide a better prognosis in the long term. That's all I have to say. This is my take-home message. As I said, back pain is multifactorial. Think about social factors, lifestyle factors, psychological factors. We need to target beliefs and behaviors. We can't just focus on muscle weakness and structural problems. Hands-on and passive modalities are fine as long as we're using them grossly for placebo effects, for neurophysiological effects, not for mechanical purposes or for therapeutic purposes. And we make sure that we don't let patients rely on those modalities, because we need to increase their control and we need to increase their self-efficacy. And using those or relying on those as a therapeutic approach is not very beneficial for chronic pain. It goes against the evidence. And use exercise for desensitization and behavior improvement. That's all I wanted to say. I hope you enjoyed it. I hope you found it beneficial. If there are any questions, I'm happy to take them. Yeah, Carlos, are you there?
Yes, I'm here, Doctora.
Okay.
I don't have questions, but maybe someone does anyone have a question?
Hello.
Hello.
Hello. Thank you, Dr. Noor, for this wonderful information. As the evidence proven that exercise is the best for treating or dealing with chronic back pain, are you facing, based on your experience, any of the, like the response from patients, how I have difficulty, for example, getting out getting up the chair, and you are using the same movement to alleviate my pain?
Are you asking if that's how I do it in the clinic?
No, I'm asking you, like, based on that, as exercise is the best to deal with chronic back pain, and suppose that when patients have a problem or the pain is increasing, affecting his movement from getting up the chair, like,
yes,
he has problem in standing from the chair. So we are going to use this movement as functional to help this patient deal with his activity. So are you facing like a problem with the patients? So they are asking how I will do this as an exercise to decrease my pain.
Yeah.
I hope I explain it.
Yeah, you did. I understand where you're coming from. So the scenarios will vary. So for example, sometimes you need to modify your exercise, and sometimes you need to listen to your patient. So I'm working usually on fear. Usually after I've done my assessment and I've given the patient a clinical presentation. So I think that you have back pain because, for example, sleep. I didn't talk about sleep, but sleep is a factor. So I'll talk about sleep a little bit. I'll talk about some behaviors that they're doing in their life that might be causing their pain. I will talk about some muscles that might be weak that we want to work on. And I'll talk about some of those fears around their pain that are avoiding the movement. So before I start, I give them a full idea. Some patients, as you said, are very irritable. So it's not wrong for a session or two to start in the bed because that's the only way they're going to activate their muscles. But what I'm trying to say is don't rely on that. Or sometimes this chair is too low. So I need to modify. I either put something to lift that chair, or I start from a much higher bench, or I lift my bed and I start my sit to stand on the bed. And I say, this is a very small range. You will reach the bed very easily. I just give them a feel of that glute activation. And then when they're more confident, I will lower that bed until we shift to the chair. So there's so many ways to deal with it. I'm not saying don't start on the bed. It depends on your patient, but make sure why you're starting on the bed. But don't give them a bed exercise program if their problem is sit to stand and then complain that they're not adhering or they're not getting better.
Yeah, exactly. Thank you so much. Thank you.
Any other questions?
I think there's a question in the chat, maybe. In acute pain, is initial rest period necessary? The short answer, no. Your role as a physiotherapist is gradual loading. That is what we do best. That is our area of strength. So you would assess the injury. You would assess the severity of tissue damage. You would assess if they need medical intervention or surgical intervention. If you feel that they do, you would refer them before you intervene. But as long as they have been cleared medically and they have been cleared surgically, then there's a protocol that you follow to gradually load the tissues depending on the stage of injury. And there's a lot of evidence out there that suggests that the earlier you load the tissues, the more you promote healing, the more you promote those collagen fibers healing in the right way. So no, you don't need rest. You just need sound clinical reasoning, where to refer. And as long as you've referred and you know they are surgically and medically safe to start working with, you start working and moving from day one. And you see that in the wards as well. So when a doctor does a total knee replacement or any type of surgical procedure, they want to ambulate those patients as soon as possible. Rest is not recommended. So no, the answer is no. You're welcome. Any other questions? I think that's it.
Anyone else? I think that's it, Doctora.
Okay.
If that's so, I think that's it. On behalf of the Scientific Committee of Ibn Sina Hospital, Doctora, would like to thank you, and thank you to everyone who participated today. This lecture will be, inshallah, will be posted in YouTube soon, and we will be posting the links in our Instagram page soon. Thank you, Dr. Noor, for a very wonderful lecture today.
Thank you. Have a good. Thank you. Thank you. Have a good day. Thank you. Bye bye.